In this video, we're going to explore the VQ scatter model of the lung. To briefly recap, in the previous video, we used the three-compartment model to explain why the end-tidal CO2 is slightly lower than arterial PCO2, that it's due to alveolar dead space, and similarly that arterial PO2 is slightly lower than alveolar PO2 due to shunting. Both of those key points are wrong. In the healthy lung, the perfusion pressures are just high enough to perfuse the apical alveoli, and hence there is no west zone 1 and no alveolar dead space. So there must be something else going on. And we must now recognize that there is also VQ mismatch, which contributes to the arterial to end tidal CO2 difference. More specifically, the high VQ component. In the three-compartment model, shunt was mixed venous blood flow going past an alveolus that was not ventilated. And from now on, I'll refer to that type of shunt as intrapulmonary shunt. That type of shunt occurs when FRC is below closing capacity. However, in the young healthy lung, FRC is above closing capacity, and hence there is no intrapulmonary shunting present. Again, there must be something else going on to explain the AA gradient, and we must now recognize that VQ mismatch, more specifically the low VQ component of VQ mismatch, also contributes to the AA gradient. This is an area of confusion for many candidates, and we will explore further how the concepts of alveolar dead space and shunt translate between the three-compartment model and the VQ scatter model. We will also look at the relationship between VQ ratios and time constants, and use that knowledge to explain why sometimes the end-tidal CO2 can be higher than arterial CO2. In the VQ scatter model, we retain the three compartments from the previous model: the ideal alveolus, which has a VQ ratio of 1, alveolar dead space with a VQ ratio of infinity, and intrapulmonary shunt with a VQ ratio of 0. But we must now recognize that the lung actually contains 500 million alveoli, all of which have their own VQ ratio that lies somewhere between 0 and infinity. So really, a 500 million compartment model would be most reflective of reality. However, such a model would be less useful because it would be so cumbersome to use. As a compromise, we group all of the high VQ units together that have a VQ ratio somewhere between 1 and infinity, and all of the low VQ units together that have a VQ ratio somewhere between 1 and 0. We should keep in mind that these groups represent a spectrum of VQ ratios, but we are able to lump them together because they cause similar effects on gas exchange, just to differing degrees. Furthermore, we should recognize that in addition to intrapulmonary shunt, there are other types of shunt as well, the extrapulmonary shunts that come from the bronchial veins and the Thebesian veins. Our definition of shunt still holds up, but we now need to understand that not all shunt is composed of mixed venous blood. The Thebesian veins drain venous blood from the myocardium and empty directly into the left side of the heart, bypassing gas exchange in the lungs. Since the oxygen extraction ratio of the heart is high, 50 to 60%, the blood in the Thebesian veins is highly deoxygenated, meaning that the Thebesian shunt would cause a greater desaturation of the arterial blood compared to a mixed venous shunt of the same magnitude. The bronchial veins drain venous blood directly into the pulmonary veins, and again, its composition would not be the same as mixed venous blood. And I haven't seen any references that tell me why these shunts exist, and I can't think of any particular physiological advantage to them, but I assume that they must be a result of the embryological development process. There may also be other sources of pathological shunt, which I haven't listed. For example, intrapulmonary AVMs or intracardiac right-to-left shunting through an ASD or VSD. But given that the exam is about physiology and not pathology, if you're going to mention them in an answer, you should first focus on explaining the physiological sources of shunt before you talk about the pathological ones. This model introduces a new concept, venous admixture, which is the amount of mixed venous blood that would have to be added to pulmonary end capillary blood to produce the observed drop in arterial PO2 from the PO2 in pulmonary end capillary blood. Now, this is a very wordy definition, and to me, the meaning of it is not immediately clear. For a moment, let's go back to the three-compartment model. And in this simpler model, there's only one type of shunt, a mixed venous shunt. And let's look back at the definition of venous admixture. It's the amount of mixed venous blood that would have to be added to pulmonary end capillary blood to produce the observed drop in arterial PO2 from the PO2 in pulmonary end capillary blood. So we can see that the term venous admixture exactly describes what shunt is in the three-compartment model. Now, shunt is the concept that we use to explain the AA gradient. So in my mind, the way I think about venous admixture is that it's everything that contributes to the AA gradient, which includes different types of shunts of different compositions and also the low VQ component of VQ mismatch. So the concept of venous admixture is trying to simplify this more complex situation back to this simpler situation, and it's treating all of these components as if they were all having the composition of mixed venous blood. And this is why people often preface the definition by saying it's a theoretical amount or virtual amount of mixed venous blood, because this situation doesn't actually exist. The other thing that's very important to understand is because we're using the VQ scatter model, when we use the shunt equation, it's not actually calculating shunt, it's calculating venous admixture. Unfortunately, having a shunt equation that doesn't actually calculate shunt is only the start of our terminology woes. The VQ scatter model is the expected level of understanding for the exam, so I advocate that for exam purposes, you use definitions that are consistent with the VQ scatter model, such that we understand that venous admixture is comprised of shunt and VQ mismatch. Whereas some other people who are more focused on the three-compartment model, they would call venous admixture shunt and say that shunt is comprised of true shunt and VQ mismatch. But I think that's too confusing and leaves yourself open for criticism. Compounding these problems is the fact that there doesn't seem to be any universally accepted classification system for shunt. The way that I've used the terms intrapulmonary and extrapulmonary shunt is actually incorrect compared to what I've read in the textbooks. But the way that I use those terms, it makes the most sense to me, and I decided to stick with it because actually the different authors don't agree with each other anyway. So for exam purposes, I would recommend that you just avoid the whole problem by not using any of these terms. Instead, you can just refer directly to what you mean. So you could say a mixed venous shunt going past an unventilated alveolus, or shunt through the bronchial veins or Thebesian veins, or VQ mismatch. There should be no need to use any of these terms. But if you do decide to use these terms in the exam, just be aware that the examiner may have a different understanding of what it means compared to what you do. Translating the concept of alveolar dead space between the three-compartment model and the VQ scatter model can also cause some confusion. In the three-compartment model, we use the concept of alveolar dead space to explain the arterial to end tidal CO2 difference. So when we move that concept over to the VQ scatter model, it's referring to everything that contributes to the arterial to end tidal CO2 difference, which is alveolar dead space and the high VQ units. And this leads some people to define alveolar dead space as alveoli that have no perfusion or reduced perfusion, i.e. alveolar dead space plus high VQ units. But the problem is that it means that when they want to refer to real alveolar dead space, they need to call it true alveolar dead space. So they're really saying that alveolar dead space is comprised of true alveolar dead space and high VQ units, which again I think is too confusing. And I would encourage you to stick with terminology that fits into the VQ scatter model only. VQ mismatch is a concept that a lot of candidates seem to struggle with, but actually once you get your head around the concept, it's actually fairly straightforward. As we've said previously, the VQ ratio of the lungs as a whole is 1, because cardiac output is 5 litres per minute and alveolar minute ventilation is 5 litres per minute. We need to be very clear about what the term VQ mismatch actually means. It refers to the situation where the lungs as a whole still has a VQ ratio of 1, but there's maldistribution of ventilation and perfusion amongst the individual lung units. Now, since having a VQ ratio of 1 is optimal for gas exchange, when there's deviation of that ratio away from 1, this is going to impair gas exchange, and we'll see that in a moment. This is an example of a lung with 5 lung units which are all optimally matched with a VQ ratio of 1. Now, if we were to introduce some VQ mismatch by changing the distribution of ventilation and perfusion, we can see that we end up with some lung units with a high VQ greater than 1 and some that have a low VQ that's less than 1. But overall, because we haven't changed the total ventilation or perfusion, the VQ ratio of the lungs as a whole is still 1. These graphs come from midget studies, multiple inert gas elimination technique studies, and they allow the quantification of the spread of VQ ratios amongst the different lung units. Now, there is a learning outcome regarding measurement of VQ inequality, but I find it highly doubtful that you would ever be asked to explain how the midget studies work. I think it's sufficient to be aware that they exist and that it is possible to quantify the spread of VQ ratios amongst the lung units. Why I include these graphs is to illustrate that in a young healthy person, there is optimal VQ matching, where most of the lung units have a VQ ratio of 1 or very close to 1. Whereas as we get older, there's an increase in VQ mismatch or VQ scatter or inequality, such that there are more lung units that have a VQ ratio that's more deviated away from 1. So this is what we mean by VQ mismatch or VQ inequality. Pause the video now and do a show me the money exercise for this question. The concentration of a gas in the alveolus will depend on the balance between its rate of inflow versus its rate of outflow. And we've already come across this principle when we've discussed hypoventilation, and we've applied it to oxygen and the lungs as a whole. Now all we have to do is realize that we can apply it to individual lung units as well. So for oxygen, if either the rate of inflow from ventilation decreases or the rate of outflow from perfusion increases, this is going to reduce the alveolar concentration of oxygen. We should also realize that we can apply the same principle to carbon dioxide as well. The difference being that carbon dioxide inflow is from perfusion and outflow is from ventilation. And this is why a change in the VQ ratio will affect oxygen and CO2 partial pressures in opposite directions. This is a diagram that you should be able to reproduce in the exam, and it illustrates the relationship between VQ ratios and the alveolar gas composition. If we start with our ideal alveolus with a VQ ratio of 1, a PO2 of 100 and a PCO2 of 40, let's first consider what would happen if there was some process that was reducing the ventilation. Well, that would mean that the VQ ratio is reducing, and if there's less inflow of oxygen and less outflow of CO2, then the PO2 will decrease and the CO2 will increase. And as the ventilation gets smaller and smaller and closer to zero, the gas composition will approach that of a mixed venous shunt. On the other hand, if there was some sort of process that was reducing perfusion to the alveolus, this would mean that the VQ ratio was increasing. And if there's less outflow of oxygen and less inflow of CO2, then the oxygen will increase and the CO2 will decrease. And as the perfusion gets smaller and smaller and closer to zero, the gas composition will approach that of alveolar dead space. And this is why we can group together the low VQ units, because they have a similar effect on alveolar gas composition as a mixed venous shunt, just to not such an extreme degree. And we can group together all the high VQ units because they have a similar effect on alveolar gas composition as alveolar dead space, just not to such an extreme degree. Both ventilation and perfusion increase going from the apex towards the base, but perfusion increases more than ventilation does. And this is how we end up with this VQ relationship where there's a high VQ at the apex and a low VQ towards the base. And this is a diagram that you should be able to reproduce and explain in the exam. Why does perfusion increase going from the apex towards the base? Well, in the previous video, we already discussed that due to the effects of gravity on hydrostatic pressure, there's increasing recruitment and distension, leading to a reduction in vascular resistance going from the apex to the base. And this is the explanation that you should use in the exam. What about ventilation? Why does that increase going from the apex to the base? This results from the weight of the lungs compressing itself, such that the apical alveoli are at a higher volume compared to the basal alveoli that are at a smaller volume. So the apical alveoli operate on the upper flatter part of the compliance curve, while the basal alveoli operate on the steeper mid part of the compliance curve. It's useful to be able to quote these numbers in the exam, but if you don't remember them, then you should be able to work them out from first principles. And as long as the numbers you use are within the right ballpark, it's fine because different textbooks quote different numbers. Armed with this knowledge, answering this question becomes very straightforward. The first part of the question asks us to describe the VQ ratio at the apex versus the base. So we would start by saying that the VQ ratio is high at the apex and lower at the base, ideally quoting some reasonable numbers, and draw this diagram to illustrate why this occurs. That is because blood flow increases more than ventilation going from the apex to the base, resulting in this VQ relationship. We then want to go on to show that we understand the underlying mechanisms of why that occurs and explain why perfusion increases from the apex to the base and why ventilation increases from the apex to the base. And it may be useful to draw the compliance curve to aid in your explanation. The second part asks us how does this affect regional gas exchange? So we would go on to talk about the balance of the rate of inflow of a gas versus the rate of outflow and how this affects its alveolar concentration. So we would draw this diagram to illustrate the relationship between VQ ratio and alveolar gas composition, or alternatively you could do it in a tabular format, but there would be no point in doing both because you would then just be duplicating information. At this point, we have already reached a 4 out of 5 standard. Why haven't we reached a 5 out of 5 standard? If we interpret this question strictly literally, we have answered everything that the question has asked. But I feel that there is an extra implied question of why does this matter, or what's the clinical significance of this relationship between VQ ratio and its effect on gas exchange. So to get full marks, I think we would need to make a comment about the effects of overall VQ mismatch on oxygen and CO2. And this is what we're going to discuss next. In explaining how VQ mismatch causes hypoxaemia, I feel like there's one crucial element that's lacking in many candidates' understanding, which is that in VQ mismatch, there are always both high and low VQ units present. And we can easily demonstrate this by analyzing a very simple lung model that has 2 alveoli. Ideally, both alveoli should be optimally matched with a VQ ratio of 1. Now first, let's consider what would happen in chronic bronchitis. This is a disease that's characterized by increased airway secretions, mucosal thickening, and bronchoconstriction. All of these factors would contribute to increased airway resistance. And the disease process would not affect every alveolus to exactly the same degree. There's a degree of heterogeneity. So let's say that this bottom alveolus is the one that's affected more by the disease, and because its airway resistance is increased, ventilation to this alveolus is decreased, which means that the airflow must be diverted to a different part of the lungs. So in creating this low VQ unit, it has also necessarily created this high VQ unit. And this is illustrated on the midget scan, that there is now a group of low VQ units, but there's also been a group of high VQ units created as well. What about emphysema? This is a disease process that's mainly characterized by destruction of lung parenchyma, and as part of that, this will result in increase in vascular resistance, and similarly, not all lung units will be equally affected. Let's say that this top alveolus is the one that is more affected by the disease process. Because its vascular resistance is increased, perfusion to this lung unit is decreased, which means that the blood flow must be diverted to another region of the lungs. And hence, by creating this unit with a high VQ ratio, we have necessarily created this lung unit with a low VQ ratio. And so on the midget scan, we can see we now have a group of lung units with a high VQ ratio, and this is associated with a group of lung units that has a low VQ ratio. We are now in a position to understand why VQ mismatch results in hypoxaemia. As we've said, both lung units ideally should be optimally matched with a VQ ratio of 1. Now we can plot the VQ ratio of a lung unit against its PO2. As we know, as the VQ increases, the PO2 will increase. And once the VQ exceeds about 100, the gas composition essentially is the same as alveolar dead space. On the other hand, as VQ ratio decreases, the PO2 will decrease, and once the VQ drops below 0.01, the gas composition is essentially the same as a mixed venous shunt. Now in this case, for both lung units, the VQ ratio is 1, corresponding to a PO2 of 100. Which corresponds to an oxygen content of 20 mL per deciliter. So when the blood from both of these lung units mixes together in the pulmonary vein, we get a weighted average oxygen content of 20 mL per deciliter, which corresponds to an arterial PO2 of 100. Let's consider now what will happen if we introduce a small degree of VQ mismatch, as is the case with the effects of gravity. Now our apical lung unit has a high VQ of 4 and the basal lung unit has a low VQ of 0.67. The high VQ unit contains a PO2 of 135, which corresponds to an oxygen content of 20.4 mL per deciliter, while the low VQ unit has a PO2 of 85, which corresponds to an oxygen content of 19.6 mL per deciliter. So when the blood from these two lung units mixes together in the pulmonary vein, we get a weighted average oxygen content of 19.7, corresponding to an arterial PO2 of 95. So this small degree of VQ mismatch has resulted in a small AA gradient. Now, when I initially see these numbers, I think, wow, isn't this quite a significant degree of VQ mismatch? We've deviated from 1 up to 4 and down to 0.67. But fortunately, in terms of effect on gas composition, this degree of VQ mismatch only has a minor effect on gas composition. Now let's consider a more extreme example of VQ mismatch, as might occur in CAL, for example. In this case, we now have a lung unit that has a VQ of 9 and the other lung unit has a VQ of 0.11. The high VQ lung unit has a PO2 of 142, corresponding to an oxygen content of 20.5 mL per deciliter. The low VQ unit has a PO2 of 47, which corresponds to an oxygen content of 15.1 mL per deciliter. So when the blood from these two lung units mixes together in the pulmonary vein, we get a weighted average oxygen content of 15.7 mL per deciliter, corresponding to an arterial PO2 of 51 millimeters of mercury. So in this case, the degree of VQ mismatch has resulted in a significant decrease in arterial PO2. How do we explain why this occurs? Well, first of all, hopefully you can see now why I'm not happy with the common explanation that's given by many candidates, that is something like this. In VQ mismatch, there are low VQ units, which are similar to shunt, and have a low PO2. Hence, they dilute the oxygen content in arterial blood and cause hypoxaemia. I can very easily point out my issue with this argument by saying, well, in VQ mismatch, there are high VQ units, which are similar to alveolar dead space. They have a high PO2, and hence augment the oxygen content in arterial blood and cause hyperoxemia. So the logic in both of those arguments isn't incorrect. The problem is that they ignore the flip side of the coin. Explaining hypoxemia due to VQ mismatch is all about explaining why the high VQ units and the low VQ units don't balance each other out. Because to the uninitiated, you might think that they should. If we just look at the PO2, we would say, okay, so well, with the low VQ unit, yeah, sure, the PO2 has been reduced, but hey, we've got this high VQ unit that has a significantly increased PO2 as well. They should just cancel each other out, because if I take the average, we get 142 plus 47, that's 189, divide by 2, that's 95. So we should have an arterial PO2 of 95. That's pretty close to 100, so there's no problem. So where is the flaw in that logic? There are actually two flaws in the argument. First of all, while the partial pressures in the high and the low VQ units look like they might kind of balance each other out, because of the shape of the oxygen dissociation curve, the oxygen contents do not balance each other out, because the high VQ unit only has a marginally increased oxygen content, while the low VQ unit has a significantly reduced oxygen content. The second flaw is that we don't simply take the average value between the two lung units. We need to take a weighted average and account for how much blood flow is coming from each lung unit. And since 9 times more blood flow is coming from the low VQ unit compared to the high VQ unit, this is why the resultant oxygen content is much closer to that of the low VQ unit. So in the exam, if you need to explain why VQ mismatch causes hypoxemia, remember that it's all about explaining why the high and the low VQ units do not balance each other out. Both shunt and VQ mismatch result in an increase in the AA gradient, so we are unable to distinguish between these two mechanisms of hypoxemia on this basis. However, the difference between the two becomes apparent when we look at the response to supplemental oxygen. We have previously discussed why a large shunt, once the shunt fraction exceeds 30%, does not respond to supplemental oxygen. On the other hand, we might have a degree of VQ mismatch which causes the same degree of hypoxemia as a 50% shunt while breathing room air, for example. But once we administer supplemental oxygen, we can see that it responds very well. Why does VQ mismatch respond to giving supplemental oxygen? As long as in the low VQ units, as long as the ventilation is not zero, then it is going to be exposed to that increased FiO2 and it will improve the alveolar PO2 in those low VQ units. And this is why VQ mismatch responds well to supplemental oxygen. We now have all the knowledge we need to answer this question, so pause the video now and do a show me the money exercise. Again, using game theory, my brain interprets this question to mean, what is venous admixture? How is PaO2 affected? And what are the effects of giving supplemental oxygen? So what is venous admixture? We start with a definition. Say that it's 2 to 3% of cardiac output, and that it's measured by the shunt equation, which we then write down. Say that it's comprised of shunt and VQ mismatch, and that there's different types of shunt with different composition. Why does it matter? Because it causes an increase in the AA gradient. How is the arterial PO2 affected? It's reduced, and we need to explain the underlying mechanisms of why. So we explain why shunt causes hypoxemia, and we explain why VQ mismatch causes hypoxemia. What are the effects of supplemental oxygen? Well, you draw the iso-shunt diagram and explain why a large shunt does not respond to supplemental oxygen, and then in contrast explain why VQ mismatch does respond to supplemental oxygen. An answer written following this type of framework would score very well. We now move on to the last two causes of hypoxemia. Increased metabolic demand will increase the oxygen extraction ratio and hence reduce the mixed venous PO2. This can lead to a reduction in alveolar PO2 and hypoxemia. Usually, the moist-inspired PO2 is 150 and the mixed venous PO2 is 40. Across the alveolar membrane, the pressures equilibrate at 100. Now, if there's increased metabolic demand and a decreased mixed venous PO2, then the pressures will equilibrate at some value that's less than 100. Normally, we should be operating at this point here with an alveolar minute ventilation of about 5 and an alveolar PO2 of 100. As we've just worked out, if there's an increase in metabolic demand, then alveolar PO2 will decrease. However, this should be sensed by the peripheral chemoreceptors, which should result in an increase in minute ventilation, and so the new homeostatic point should be here, with a normal alveolar PO2, but at the expense of increased minute ventilation. So if we start off at this point, and instead of ending up at this point here, we end up here, is this hypoxemia due to an increase in metabolic demand, or is it hypoxemia due to hypoventilation? This is why I say that increased metabolic demand is an indirect cause of hypoxemia. As a secondary mechanism, the reduction in mixed venous PO2 will also accentuate the effects of any venous admixture that's present. And again, this contributes to a secondary mechanism of hypoxemia. On emergence from a nitrous oxide anesthetic, there is rapid outgassing of nitrous oxide from the blood into the alveoli, leading to a dilution of the alveolar PO2. And this dilutional effect occurs because of the different blood solubilities of nitrous oxide versus nitrogen. A larger volume of nitrous oxide outgasses from the blood into the alveolar gas versus a smaller amount of nitrogen that's dissolving from the alveolar gas into the blood simultaneously. As a secondary effect, the alveolar PCO2 is also diluted, which results in a reduction in hypercapnic drive. The final topic that we'll be covering is the relationship between VQ ratios and time constants. Do a show me the money exercise for this question. This question requires you to recognize that there are potentially physiological causes for a difference and also equipment causes. Regarding physiological causes, it can lead to the end-tidal CO2 being less than arterial, or it may be greater than arterial. As we've previously discussed, generally the end-tidal CO2 is slightly lower than arterial CO2, and we explain this using the concept of alveolar dead space. Because this is such an important and fundamental concept, according to the examiner's reports, if you explained alveolar dead space and one other mechanism of causing a difference, this was sufficient to achieve a pass in this question. A short expiratory time would also lead to end tidal CO2 being less than arterial CO2, and we will talk about that in a moment. Regarding end tidal CO2 being greater than arterial, this can happen when there's increased heterogeneity of time constants, and a long expiratory time will also contribute to this. Regarding equipment factors, there are multiple causes of measurement error relating either to the capnograph or to ABG analysis, and so there are many things that you could have included in this answer. A time constant is a parameter that characterizes an exponential decay process. And when we apply this concept to the lungs, we can say that one time constant is the time it takes for a lung unit to inflate or deflate to 63% of its final volume. Mathematically, it's equal to the airway resistance times by the compliance. And we can intuitively understand this using the analogy of blowing up a balloon. That if we blow up a balloon, it's going to take a certain amount of time. If we instead blow it up through a very narrow, thin straw, it's going to take a longer time to blow it up because of the higher resistance. On the other hand, if we have a second, much more distensible balloon, it's going to take a longer time to blow up to the final volume because it has a higher compliance. Once that makes sense to you, the next step is to understand that fast alveoli with a short time constant will have a high VQ ratio, while slow alveoli with a long time constant will have a low VQ ratio. The easiest way to rationalize this is to think about a lung unit with a high airway resistance. We can easily understand that this is going to mean that it has a long time constant, making it a slow alveolus. And if airway resistance is high, it's going to slow down airflow to the lung unit, reducing its ventilation and hence reducing its VQ ratio. So a slow alveolus will have a low VQ ratio. The final step is to integrate this understanding. Since a fast alveolus will empty earlier than a slow alveolus, this means that high VQ lung units will empty before low VQ units. And high VQ units have a lower PCO2 in them, while low VQ units have a higher PCO2 in them. And this is why phase 3 of the capnograph is upsloping, because high VQ units are emptying earlier than low VQ units. And the sloping will be exacerbated if there's anything that increases the heterogeneity of the time constants. There are two reasons why phase 3 of the capnograph is upsloping. As we've just explained, the first reason relates to heterogeneity of time constants. That fast alveoli with a high VQ ratio empty before slow alveoli with a low VQ ratio. The second reason is something that we've been completely ignoring up until this point in all of the lung models that we've used. That's the fact that ventilation is phasic, that there's an inspiratory phase and an expiratory phase. On inspiration, the fresh gas which contains no CO2 is delivered down to the alveolus, and hence it will dilute the CO2 concentration in the alveolus. So by the end of inspiration, the alveolar PCO2 is at its lowest value. During expiration, because there is a partial pressure gradient between the mixed venous PCO2 and the alveolar PCO2, CO2 is constantly diffusing across the alveolar membrane and increasing the alveolar PCO2. So during the expiratory phase, alveolar PCO2 increases. And in fact, if the expiratory phase is prolonged, then the PCO2 will continue to increase until it reaches and equilibrates with the mixed venous value. And this takes about 10 seconds to occur. Now we have all the tools we need to explain the difference between end tidal and arterial CO2. The most important cause is alveolar dead space, which increases the arterial to end tidal CO2 difference. Now that we understand why phase 3 is upsloping, it's easy to see that a shortened expiratory time will result in a lowering of the end tidal CO2. Some textbooks refer to this as incomplete emptying of low VQ units because the slow alveoli with low VQ don't have time to completely empty. Similarly, we can understand why a prolonged expiration would result in a higher end-tidal CO2 as the value approaches that of mixed venous CO2, such that sometimes end-tidal CO2 may be greater than arterial CO2. And this process will be accentuated by increased heterogeneity of time constants. And this is why we say that the alpha angle gives us an index of the VQ status of the lungs, because increased heterogeneity of time constants would result in the slope of phase 2 being less steep and the slope of phase 3 being more steep, increasing the alpha angle and also being associated with an increase in VQ mismatch. We have used the VQ scatter model of the lungs to gain a more nuanced understanding of the causes of the arterial to end-tidal CO2 difference and the AA gradient. For exam purposes, it's important to be able to explain how VQ mismatch causes hypoxaemia and why its response to supplemental oxygen differs from that of shunt. By understanding the relationship between time constants and VQ ratios, we gain a better understanding of the shape of the capnograph trace. We have reached the end of this 3-part series on respiratory physiology. I hope that you've gotten something out of it, despite the fact that almost everything we've covered is in some way incorrect or incomplete. The more you understand, the more you realize that there's so much more that you don't understand. But don't let this overwhelm you. The degree of detail that we've covered in this series is easily more than enough to score well in the exam. So you should think over these concepts until they make sense to you. And even if your answer doesn't sound polished or slick, it doesn't matter. As long as you demonstrate understanding, you have reached the passing standard.